So I thought I will just lead through some of the basic principles of eye movement. Then each system convolved one week I will take, and then I will show some eye movements, maybe some 4 or 5 sessions on eye movement, then some bladder, tone, like that, some basic topics I will cover. I am thinking like that. So why do we have an oculomotor system? To see the world, we have got the optic nerve and the visual pathway. Then why you should have an eye movement? So this is because this system maintains function to foveate, because the object will be seen very clearly only if the image falls on the fovea. That is, then the visual pathway will pick it up. So who will put it on the fovea? So for that we need the motor system. So it is to foveate by finding, fixing, focusing, aligning, and following. So the motor system finds the target of interest, fixes it, focuses, aligns, and follows. And foveation results in proper visual acuity, single mental image. Otherwise, each eye is in one plane and each visual pathway is carrying the structure to the occipital lobe, and you will see 2-3 images. So this results in a single image. And binocular stereoscopic vision. Both eyes are needed for depth perception. That is the 3-dimensional vision. So the motor control is helping to put the object on the fovea and prevent multiple images. Each visual pathway should not process one image of the same object. And then it produces a 3-dimensional vision. And foveation is taking place constantly, always, for moving eyes, moving targets, and both. We know that eyes are moving always, targets are moving mostly, and both should be put on the fovea, and that is done by the oculomotor system. And okay, this is some quotation. So Krishna Paramahamsa said, if you look outside, you will not know where you are heading. Look inside. Eyes provide only the sight, but heart provides the way. And always look at how far you have come rather than how far you have to go. Always count your blessings and not what you are missing. So that is a good quotation. I thought seeing outside, seeing inside, and foveating, I thought I'll put it there. Thigh movements, they rotate medially and laterally around the vertical axis for rotation. So for rotation, there is a vertical axis. So the rotation takes place around a vertical axis, medially and laterally. And upward and downward movement takes place around a horizontal axis. So upward, downward. That is taking place. So vertical axis for rotation, horizontal axis for up and down movement, and torsion inward or outward takes place in the anterior-posterior. So you have got an anterior-posterior axis in which torsion takes place, and horizontal axis in which upward and downward movement takes place, and you have got a vertical axis in which medial and lateral movement. So medial lateral movement is through the vertical axis, up and down through the horizontal axis, and torsional movements in an anterior-posterior axis, intorsion, extorsion. So those are the 3 important axes: the vertical axis, horizontal axis, and anterior-posterior axis. Vertical axis for medial and lateral rotation, horizontal axis for upward and downward movement, anterior-posterior axis for torsion. So very important basic things. Then I will tell how to do this abnormal. So why we need movements? That's what we are going through. Clear visualization of the environment requires that its image be held in the central foveal region, as well as it remains steadily on the retina. You should be put on the fovea and remain on the retina. The range of retinal movements allowed for clear vision is less than 5 degrees per second for objects with higher spatial frequency. So more than 5 degree dislocation, if the eye movement and fovea is not clear, it will become blurred. So up to 5 degrees, the blur will not be there. So the image should be within 0.5 degrees from the fovea. So for clear, so if it is rotating more than 0.5 degree, the image will not be clear. So a lot of motor activity has to take place to bring it to the fovea. So the range of retinal movements allowed for clear. That what is we mean by retinal movement is When the image slips from the fovea, the image will slip away from the fovea and fall on the retina and scatter. So that retinal scatter, if it is less than 5 degrees per second, clarity can be maintained. More than that, clarity will not be there. 1 minute, I will come. So remember all these basic points, then only you will understand what you are seeing in the abnormality. So you have got a horizontal axis, anterior-posterior axis, and a vertical axis. Catch each point so that you will learn eye movement in a very mathematical way. And what do they do to compensate for head movement? So when your head moves, one is the target might move, eye might move, and the head might move. And when the head moves, how are you putting the object on the? So when an object moves, I told when it slips on the retina more than 5 degrees, the blur will come. So foveation takes place. Next, when the head moves, what happens? When the head moves, it is sensed by vestibulo-ocular system. You have got the labyrinth. Each one I will be dealing with in subsequent sessions. I am repeating so that these basics you understand and abnormal eye movements no more or just by heart. And like that is my idea. So vestibulo-ocular system is the labyrinthine sensors. You have got the semicircular canal. I will be dealing it with the next session. You have got the fluid column, endolymph, into which the hair cells are moving and they sense the head movement and generate compensatory movements to foveate. Next is constant rotation. Vestibular ocular reflex is for short head rotation. And optokinetic nystagmus is for constant rotation. Suppose you are moving in a train and the environment is continuously moving. There should be a movement which does not adopt. So optokinetic system does not adopt. Vestibulo-ocular system will adopt after brief head rotations, whereas optokinetic system will not adopt. So continuously moving target will be fixed on the fovea by the optokinetic system. Then smooth pursuit is following movement. So when the head moves, it may be a brief head rotation that is foveated by the labyrinth. So brief head rotation, foveation takes place through the labyrinth, vestibulo-ocular reflex. But as you know, I will be dealing with this later. Vestibular uniform oscillation in a fluid column produces inertia. That is a physics principle. So because of that, after some time, the labyrinthine organ stops sensing. Yes, uniform oscillation is continuously happening means labyrinth will stop responding, so that will adopt. So you have the optokinetic system which does not adopt. It is based on occipito-mesencephalic pathway, which is not a fluid-filled chamber. So the inertia of movement is not applicable there. Next is the smooth pursuit, is a smooth following movement where the head movement occurs following a uniform speed following target. So these are the three corrections which compensate for head movement. One is vestibulo-ocular, which is brief because inertia of fluid column. Okay, is occipito-mesencephalic, it does not adopt. Smooth pursuit is for continuously following a slowly and uniformly moving target. And and another thing is the vergence. So supposing you have got a object which is in the center, you converge and put the object on both fovea. Or if you have an object which is very far, you diverge and put it on both fovea. So for objects which are close or far away, you have got convergence or divergence. So we need the eye movement to bring the target of interest to the fovea and to shift the line of sight in a need-based way. So an object is put on the fovea, okay? You are seeing that, but suddenly you want to see another object. You are now watching a PPT, but you want to watch a bird that is flying. So you have to shift the line of sight in a need-based way. So one is to fix it on the fovea. Second, to shift away from the fovea. That is to shift the line of sight in a need-based way. Voluntarily, you want to see something else, so you have to shift it also. And to oppose the viscous drag of the orbital contents. And during these phenomena, you have the mechanical content in the orbit, like the connective tissue, you have got the muscles, you have got the ligaments and tendons of muscles. All these give a viscous drag to the content of the orbit, so I cannot move. So you need an eye movement control to bring the target of interest to the fovea when you are fixing on a target in front of you. And once you want to shift away from a target, again you need the eye movement, so based on your interest. So to bring it to the fovea, shift it away from the fovea, and this will be opposed by the mechanical content in the orbit, like the fat, connective tissue, muscles, tendons, and nerves. So that has to be opposed, and the eye should move against the mechanical restraint imposed by this non-functional connective tissue inside the orbit. So these are the requirements for an eye movement. And so we have, for this we have got eye movements, those which stabilize gaze and keep image on the retina. So as we told, these initial parts, if you study, then eye movements, nobody has to mug up. So those which stabilize gaze and keep image on the retina. So you are seeing an object, you are reading a notebook or something like that, and the image is brought to the fovea and it is stabilized there as long as you want to be on that. You are studying a picture and you want to be there for 5 seconds, 10 seconds, till then you should be fixed there. And then second, as I said, those which shift gaze towards a new object. So those which stabilize gaze on the fovea and those which shift gaze towards a new object. These are the movements which are generated for carrying out this purpose. So what are the gaze shift movements and what are the gaze maintenance movement? Gaze shift movements are saccades, smooth pursuit, and vergence. So what is saccade? It's a very fast movement. This brings image of object of interest into the fovea quickly. So when a foreign body is coming to hit you, even though you are reading your laptop or listening to some presentation, some foreign body or insect is coming, you have to protect your eye. So then you quickly shift. What is that shadow I saw? So that is gaze shift from a fixed position of the eye. That is a fast movement, that is saccade. So to bring image of object of interest onto the fovea quickly, that is a saccade. What is a smooth pursuit? To keep the image of a slowly moving target. As I told, an unexpected, unanticipated target like an insect, you cannot smoothly follow. There you need a saccade. That is for a quick gaze shift. For a slow gaze shift, you have got a slowly moving object and you are slowly shifting your eye. That is smooth pursuit. And vergence, to move the eyes in the opposite direction. So to focus on an object which is kept in the center or far away, you have to converge or diverge. So this is vergence system. So gaze shift movements are saccades, pursuits, and vergence. Saccade is for quick shift of gaze. Pursuit is for slow following up of an object. And vergence is for anterior-posteriorly placed target to move eyes in the opposite plane. They both come inside or move outside. So that is gaze shift movements. So gaze maintenance, to maintain a moving environment. You are in the train is moving forward, the environment is moving backward, and you want to maintain your gaze on what is coming in front of you. For that, we have got optokinetic movement. All of us have seen when we travel in the bus or train, the person in front of us will show nystagmus. That is called optokinetic nystagmus. And this optokinetic nystagmus maintains gaze on the area in front of your window. You don't want to see the object which has crossed or which is in front. You just want to maintain your field of vision across the window, means it is optokinetic system. Then you have got the vestibular system to hold images on the retina during brief head rotation. As I told, there is inertia of motion in the fluid column. So vestibular system will work only maintain gaze during brief head rotation. And fixation is to hold eyes conjugately in a particular position. So gaze maintenance system is optokinetic system for sustained rotation, vestibular system for brief rotation, and fixation is a synthesis of all these to hold eyes conjugately in a particular position. And gaze shift from one target to other for quick shift is Saccadic, slow continuous shift is smooth pursuit, and opposite shift is vergence, and vergence which is convergence or divergence. So what are the movements that happen? The eye movements which compensate for head movements are vestibulo-ocular reflex and optokinetic nystagmus. Vivo are for brief, OK and for sustained. And spontaneous target-oriented movements, saccades, vergence, pursuit, and anti-saccade. What is anti-saccade? Is moving the eye away from. Supposing you see some very dangerous thing which you don't want to see. So voluntarily using the frontal attention system, we will move the eye away from that. You see blood or you see something which is very uncomfortable for you, you do anti-saccades. Then you have got eye movements which take place at the lower motor neuron, and you have got eye movements which are abnormal. So these are eye movements which compensate for head movement, and eye movements which compensate for targets. They are supranuclear movements. Whereas voluntary end organ is the lower motor neuron which executes the eye movement. And you have got abnormal eye movement which could be due to lower motor neuron disease or either the control mechanisms for gaze shift or gaze maintenance which is upper motor neuron. So now we will see what are these. What is vestibular movement? Holds images of the seen world steadily on the retina during brief head rotation. Endolymph, you have got stereocilia, kinesiocilia. They bend when the head rotates, and this bend produces electricity that is carried through the vestibulo-ocular nerve to the cerebellum, and then so that becomes a mathematical formula to assess head rotation. Because the fluid column will have inertia, vestibular is for brief head rotation. I am sure all of us know that you put a paper boat in a tray and move the tray uniformly. That experiment all of us have done, and after some time, the paper boat stops moving. That is because uniform oscillation in a fluid column produces inertia. That is why vestibular system adopts. And visual fixation holds the image of a stationary object on the fovea. So vestibular movement is brief rotation, fixation is stationary object, optokinetic movement holds images of the seen world steadily on the retina during sustained head rotation. During sustained rotation, as I told you, are moving forward in a bus or train and the environment is moving backward. So there is sustained rotation. And what is smooth pursuit? Smooth pursuit holds the image of a small moving target on the fovea. So it just follows a moving target. Optokinetic drum is there. So it is moving. So it follows the slowly moving object. And nystagmus quick phases reset the eyes during prolonged rotation. Optokinetic nystagmus is a physiological nystagmus. When there is a sustained environment and person moving in opposite direction, it resets the eyes during prolonged rotation and directs gaze towards the oncoming visual scene. The environment has moved back, you have moved forward, and it brings the object which is in front to the area of interest. That is quick phase of nystagmus, optokinetic nystagmus, a physiological nystagmus. And saccades bring images of objects of interest into the fovea quickly. And vergence moves the eyes in opposite direction so that image of a single object are placed or held simultaneously on both fovea. So vergence is to hold a single object in both fovea simultaneously. So next, we have briefly seen what all these words meaning. This you should become thorough if you want to follow and understand my series, at the end of which nobody has to teach you abnormal movement, you will only derive. Then types of movements are versional movement and vergence movements. What is this term? Version movements. They are conjugate. Conjugate means both eyes are moving simultaneously. They are versional movements. Vergence movements means disconjugate movements. Each eye is moving in a non-cooperative way. That is vergence movement. So vergence is either convergence or divergence, whereas version is movement to the right or movement to the left, like that. Conjugate movements are called versional movements, and disconjugate movements are called vergence movements. So now to see the summary, you have got eye movements, you have got versional movement, and you have got vergence movement. Disconjugate is vergence, that is convergence or divergence. Version is conjugate, that may be saccade, that may be smooth pursuit, optokinetic or vestibular ocular. That means both eyes are participating in the same, with the same interest. Saccade moves right eye to the right and left eye to the right. Smooth pursuit moves right eye to the right, left eye to the left slowly. That is what version, that is conjugate movement. So under conjugate version movements are saccade, smooth pursuit, optokinetic movement, and vestibulo-ocular movement. And vergence movement is convergence or divergence. The axis of eye rotation, that what I told first, we should remember you have got a vertical axis, you have got a horizontal axis, and you have got an anterior-posterior axis in which various movements take place. And when do we use the term duction? The duction refers to monocular movement of each eye. That is element. So monocular movement of each eye is duction movement. Version refers to binocular, conjugate movements of both eyes, such as that the visual axis of eyes move in the same direction. Vergence refers to binocular, disjunctive movements such that the visual axis of the eyes moves in opposite direction. These words, we should not have confusion when we go to abnormal movements and we describe them. So that is why I am elaborating this and I am repeating. So you have got the vestibular movement, the haze holding movement. Keeps images steadily on the fovea during brief head rotation. Fixation holds image of a stationary object on the fovea. Optokinetic keeps images stable on the retina during prolonged sustained rotation. Smooth pursuit holds images of small moving objects steadily on the fovea. Saccade is fast. Vergence is both eyes move in opposite direction. And nystagmus of the fast component brings the object of interest in front to the fovea in a moving situation of the patient and the environment. So these are various movements and basic terminologies which we should know to understand as we go up in these sessions. And what are the types of target? Anticipated target. Like when you are going to the mango tree, you are anticipating a tree and mangoes. So they are anticipated target, and what you want to do with them, you have a plan. And moving targets. So target may be moving or stationary. And you have got stationary target. And you have got unanticipated or novel targets. So movements are not only because of head movement, because of eye movement, but also because of the nature of the target, which may be anticipated target, it may be a moving target, it may be a stationary target, or it may be a totally unanticipated novel target. And in the lower motor neuron, we have got the muscles, the myoneural junction, the nerves, and the nuclei of the nerves. Up to this is the lower motor neuron. This session is only some words and some anatomy. So these are the lower motor neuron structures. We know we have got the superior rectus, superior oblique, lateral rectus, medial rectus, inferior rectus, inferior oblique. So these are the various muscles, the recti and the obliques. And we know that each muscle, depress. The inferior rectus will depress. So you have got the recti, which move the eye in the horizontal plane, and the lateral rectus and the medial rectus. Superior rectus elevates, inferior rectus depresses, and inferior oblique elevates, and superior oblique depresses. Then combined, there are more than one action for each muscle. Superior rectus is elevation, intorsion, and it is vertical recti adduct. So elevation, intorsion, and adduction. So superior rectus is elevation, intorsion, and adduction. And inferior rectus is depression, extorsion, and adduction. So vertical recti will adduct. Vertical rectus is superior rectus, inferior rectus. They both adduct. Inferior rectus depresses, superior rectus elevates. Superior rectus intorter, inferior rectus extorter. Lateral rectus is abduction. Medial rectus is adduction. And inferior oblique, elevation, extorsion, abduction. So vertical oblique will abduct. So inferior oblique will abduct, extort, and elevate. Superior oblique will depress, intort, and it will produce depression. So to summarize this, recti act better in the abducted eye. So if you want to check the recti, you should check in the abducted position. Obliques act better in the adducted eye. Superior muscles intort. That is superior muscles intort. Superior rectus and superior oblique, they intort. Inferior muscles extort. That is inferior rectus and inferior oblique. Vertical recti adduct. That is superior rectus and inferior rectus, they adduct. Vertical oblique abduct. Superior oblique, and this is the formula. So recti act better in the abducted eye. Obliques act better in the adducted eye. Superior muscles, superior rectus and superior oblique, intort. Inferior muscles, inferior rectus and inferior oblique extort. Vertical recti, superior rectus and inferior rectus adduct. Vertical oblique, that is superior oblique and inferior oblique abduct. Then horizontal act recti, only one adduct or abduct. We saw that the vertical muscles have torsional component, adduction, abduction, elevation, depression. Whereas horizontal muscles have only adduction or abduction. Then other peculiarities, superior rectus. These will all reflect on abnormalities. So remember, superior rectus has supply from the contralateral superior rectus nucleus. You have got the Warwick model in the third nerve. So superior rectus nucleus supplies contralateral superior rectus muscle. Superior oblique also contralateral because it crosses in the dorsal midbrain. Now levator palpebrae superioris is having bilateral innervation. And Edinger-Westphal nucleus is a single structure that provides parasympathetic innervation to both. So levator palpebrae superioris and Edinger-Westphal nucleus is a single nucleus for both sides. Superior rectus is contralateral innervation, superior oblique also contralateral innervation. Then we'll come to the brainstem. The brainstem, what are all the structures? So we started with the higher control, then we came to the element, and now we are coming to the brainstem. In the brainstem, this information is processed in neural integrator. So what is neural integrator? It integrates the position of the target, position of the eye, position of the head, and produces a formula so that the correct speed, velocity, and amplitude of the eye movement is formulated. And this neural integrator consists of parapontine reticular formation and cerebellum. And there is another structure which fine-tunes this, that is called 3-neuron arc, which is constituted by PPRF, vestibular nucleus, and perihypoglossal nucleus. So in the brainstem, integration of the moving target or stationary target or novel target, head position, eye position, body movement information is integrated into a formula by neural integrator, which is PPRF and cerebellum, and another 3-neuron arc, which is synergistic, that is PPRF, vestibular nucleus, and perihypoglossal nucleus. Then other structures which control are medial longitudinal fasciculus. When you go, each one will be dealt separately, then it will become more clear. And in the brainstem, apart from the neural integrator and the 3-neuron arc, the structures which are vital are medial longitudinal fasciculus, the interstitial nucleus of MLS, the nucleus of Gajal, the nucleus of Dakshivit. It's a small accessory oculomotor nucleus that lies along the central gray region, and fibers project to the posterior commissure. It is involved in lid retraction, lid movement, Collier sign or lid retraction. Then you have got the reticular formation and superior colliculus. Reticular formation is for attention, which is very important for visual fixation, and superior colliculus has got two portions. One portion is for novel target and another portion is for field. So these are the structures: medial longitudinal fasciculus, interstitial nucleus of MLF, nucleus of Gajal, nucleus of Dakshivit, which collects the posterior commissure and controls lid movement, and reticular formation for alertness and attention, and superior colliculus for novel target recognition and field recognition. The superior and inferior part. Superior part is for novel target. We thought different kinds of target are there. Unanticipated target is processed in the superior colliculus, and inferior colliculus, inferior part of the superior colliculus is for field. Then in the cortex we have got, so we went through the element, brainstem structures, the neural integrator, 3 neuron arc, and other accessory structures in the brainstem. Then we go to the cortex. You have got the frontal eye field. Frontal eye field, which is for attention related movements, and you have got area 8 and its connection to the area 6 and frontomesencephalic pathway. And you have got occipital eye field and occipitomesencephalic pathway, and you have got cerebellum and cerebellomesencephalic pathway. So in the cortex, the eye movements are processed by the frontal eye field, and it descends to the midbrain through the frontomesencephalic pathway. You got the occipital eye field and descend to the brainstem through the occipitomesencephalic pathway. They got cerebellum and cerebellomesencephalic pathways. And you have got accessory systems, which are vestibular system, cervico-ocular system, and cervico-colic system. That is the muscles, neck muscles, and then you have got the neck and the eyes and vestibular system. Each one I will separately tell, but you be very clear, because the purpose of this theory session is to make clear understanding of eye movement and not mug up, which may not be possible in a case discussion, and also students are not taking cases now. So I thought I will take one topic in a full way so that it becomes easy for people. Then you have got some laws, the laws of eye movement, law of reciprocal innervation of Sherrington. So according to this law, before the next Wednesday, you should be thorough with all this we are sharing today. So law of reciprocal innervation of Sherrington: an agonist muscle receives a neural impulse to contract, an equivalent inhibitory impulse is sent to the neuron supplying the appropriate antagonist muscle, resulting in relative relaxation of the antagonist. There. So when an agonist receives an impulse to act, antagonist releases an impulse to inhibit. So that is Sherrington's law of reciprocal innervation. This can fail. That results in some conditions. Then you have got law of motor correspondence, that is Herring's law. Conjugate eye movements require coordinated yoked pairing of extraocular muscles. So right lateral rectus should pair with the left medial rectus. That is called yoked muscles. Only then you can carry out a gaze movement. If you want to move your eye to the right side, right lateral rectus should pair with the left lateral rectus. So that is called law of motor correspondence or Herring's law. And Donder's law is, after returning to the initial position, the retinal meridian is oriented exactly as it was before the movement was initiated. So after the movement is carried out, all eye position returns to the primary resting position to visualize the next target. That is Donder's law. And Listing's law, it implies that all eye movements from primary position are true to the meridians that we saw, the horizontal, vertical, and anterior-posterior, and occurs without torsion with respect to the primary position. So that is Listing's law. Then you have got the oculomotor nerves, the brainstem structures, mesencephalic reticular formation, and superior colliculus. And you have got the gaze center, which consists of, next we saw PPRF, and PPRF is a gaze center, and it consists of what types of neurons? You have got excitatory burst neuron, that is agonist, omnipass neurons that maintain the position. Once the burst has happened, it has to reach a position. That is done by the omnipass neuron. And tonic neurons, they keep it in the position for longer time. And the neural integrator integrates all this. And you've got inhibitory burst neurons. You've got excitatory burst neuron, inhibitory burst neuron, tonic neuron, and omnipass neurons. And the inhibitory burst neurons are seen in the nucleus parajejanda cellularis dorsalis in the dorsomedian part of the dorsal medulla, and that produces inhibitory burst to the opposite muscles. We saw the pairing of muscles. So antagonistic muscle is inhibited by the inhibitory burst neuron. Then you have got vertical gaze, which is excitatory by the rostral interstitial nucleus of MLS, and the neural integrator for the vertical gaze is interstitial nucleus of Gajal, and the inhibitory burst neurons for this is in the nucleus paraphilus. So you have got for the supranuclear control frontal eye field, it is anterior to the premotor cortex, Brodmann's area 8, and it initiates voluntary, non-visually guided, controversive saccades. And parietal eye field, it is seen in the lateral bank of the intraparietal sulcus. Inside the parietal, you have got intraparietal sulcus, which is, so it is in the lateral bank of the intraparietal sulcus, adjacent to Brodmann's area 7A. Initiates voluntary, visually guided, and controversive saccades. And supplementary eye field, anterior to the supplementary motor cortex, that is area 6, dorsal median frontal lobe. And it is involved in planning and learning of saccadic movements. So in the frontal lobe, you have got the frontal eye field and you have got a supplementary eye field, area 6. And in the parietal field, in the banks of the parietal lobe, that is mainly for anti-saccades and controversive saccades and visually guided saccades. And dorsomedian frontal lobe, Brodmann's area 9 and 46 is involved in memory guided saccades. Saccades towards a remembered object. You enter into a house and where you have seen a Krishna or some statue, and suddenly you want to generate a saccade there based on previous memory. That is taking place in the Brodmann's area 9 and 46. And superior colliculus, caudal midbrain, and it is situated in the caudal midbrain and posterior to the periaquedual gray, and regulates excitatory and inhibitory signals invoked in the generation of saccades and control of eye movement and head movement for novel target. This is for unanticipated novel target. We call it as collicular vision or blind sight. So it's not consciously appreciated. Novel targets are prevented by saccades generated by the superior colliculus to protect the eye. And paramedian pontine reticular formation, that is the paracentral pons, anterior and lateral to the medial longitudinal fasciculus, and directs projections to the effector extraocular muscles to move the eye. So very important to remember all these things. You have got a frontal eye field, you have got a parietal eye field, supplementary eye field, dorsomedian prefrontal eye fields for top-down processing of remembered objects, superior colliculus for novel target, and parapontine reticular formation for fixation of the extraocular muscles. Then you have got cell population in saccadic control. You have got the burst neuron, you have got pass neuron, and you have got tonic neuron, and you have got the extra lower motor neuron which executes it. Omnipass neuron distributed throughout the midbrain and pons, and it exerts tonic inhibitory effect on the burst neuron to prevent unwanted saccades. So omnipass neuron is throughout the pontomesencephalic region, and it exerts tonic inhibitory effect on the burst neurons to prevent unwanted saccades. Burst neuron is paramedian pontine reticular formation and rostral interstitial nucleus of the MLF, and it control of pulse of innervation to initiate saccades. So as we saw that there is a viscous drag in the orbit due to the mechanical property of the connective tissue, the muscles, the nerves, the fat. So to generate a movement, you need a pulse innervation, a very powerful push that comes through the burst neurons. And the motor neurons which carry it out are the abducent nucleus, oculomotor and trochlear nucleus for various types of movements. And you have got the interneurons, that is abducent nucleus for horizontal movement, and you have got oculomotor and trochlear nucleus for vertical movement. They are linked by interneurons. Then we have got the pursuit system, that is occipitomesencephalic. It starts from the occipital cortex, and the target is fixed by the frontal eye field, and then it is through the occipitomesencephalic pathway, it comes the neural integrator, and thus the slow following movement. That the smooth pursuit system is occipitomesencephalic, but the attention comes again from the frontal only. So this each system I will deal with. Now I have just covered the anatomy, and for fast movements, the saccadic movement. Saccadic system is a fast movement. It is frontomesencephalic and it is attention related. So fast movements are frontomesencephalic, and burst neurons, inhibitory neuron, omnipause neurons are involved in the brainstem, and but starts from the frontal lobe and ends in the brainstem to carry out fast movements. So what I feel. So next, so this just covered a broad outline of anatomical structures and the purpose of eye movement. This you should become very thorough. Next will be Virgin's vestibular system. Next, I am planning to take vestibular control. We thought that during brief head rotations, vestibular system is corrected. So normal anatomy, normal physiology, 3-4 sessions, then 1 session for abnormal eye movement reporting. That will be more interactive. So if you have followed these sessions, you can interact and find out the abnormal eye movement. That is my plan. So next will be vestibular system. So any difficulty in this area you ask, but you should go through, read, so that you are ultimately able to spontaneously register, record all the abnormalities you see in a patient and derive it mathematically and say what it is.